This entry in the series is about atropine and pralidoxime, corresponding to antidotes in depth chapters A35 and A36 in Goldfrank's Toxicologic Emergencies. The learning objectives for this session are that you'll be able to explain the mechanisms of action for atropine and pralidoxime in treating anticholinesterase poisoning, and to outline dosing regimens for atropine and pralidoxime when used as antidotes for this purpose. Atropine is first-line therapy to treat the muscarinic effects seen with organophosphate and carbamate toxicity. And why would you want to do that? Basically, to prevent the patients from drowning in their own secretions. Remember the killer bees that are part of the mnemonic to remember what's seen in a cholinergic crisis? One of those bees is bronchorrhea, excessive pulmonary secretions induced by excess muscarinic tone, as will occur with anticholinesterase poisoning. Here are the textbook's recommendations about atropine dosing. There's initial dosing, a dose escalation protocol, and then maintenance dosing. The initial dose of atropine in mild to moderate poisoning is 1 to 2 milligrams IV. With severe poisoning, basically patients who are so sick they're unconscious, the initial dose is 3 to 5 milligrams. And those are the recommended adult doses. In children, the recommended starting dose is 0.02 milligrams per kilogram. If that first dose isn't enough to control the muscarinic findings, you start doubling the dose and giving another dose every 3 to 5 minutes until the patient's condition has improved. The primary endpoint for determining adequate dosing is reversal of bronchorrhea. The authors recommend that the goal is to achieve clear lungs on auscultation, a heart rate over 80 per minute, and a systolic blood pressure above 90 millimeters of mercury. Once you've achieved this goal, you stop doubling the doses, but you remember how much you gave in the latest dose, and repeat that dose as necessary if and when symptoms return. And you also start an IV maintenance drip of atropine at a dose of 10 to 20% of the total atropine load given per hour. For example, if you started with 2 milligrams and then gave 4 milligrams and then 8 milligrams, that's a total of 14 milligrams in the loading dose, so the maintenance infusion to start would be 1.4 milligrams per hour. Typical doses needed for the maintenance dose range from 0.5 to 1.5 milligrams per hour. But even then, the patient needs to be closely monitored and additional IV atropine boluses given and/or adjustments in the maintenance infusion rate made as needed. The total atropine dosing needed to treat serious organophosphate or carbamate poisonings can be quite high. For instance, even in cardiac resuscitation efforts, patients will typically get no more than 3 milligrams of atropine. But with anticholinesterase insecticide poisoning, patients might use up an entire hospital's atropine supply, getting dozens of milligrams. And if you find yourself in that kind of situation, you may need to consider alternative antimuscarinic medications, say like glycopyrrolate as a substitution. On the other hand, there's some, I guess we'll call it, good news if you're treating people exposed to anticholinesterase nerve agents. Treatment of nerve agent exposures typically requires less atropine compared to organic phosphorus compounds or carbamate insecticide poisoning. Switching now from atropine to pralidoxime. The oximes are a group of nucleophilic drugs that can regenerate acetylcholinesterase that has been inhibited by organic phosphorus compounds. The only commercially available oxime in the United States is pralidoxime. It happens to go by several different names. First, it's actually a salt, and the commercially available product is pralidoxime chloride. The most common trade name is protopam, which includes the PAM abbreviation of its chemical name, 2-pyridine aldoxime methylchloride, or 2-PAM. There are other oximes used in other countries, and the most common of these is obidoxime in the UK, Europe, and elsewhere. I especially like its trade name, toxogonin, which makes me wonder if it's supposed to make you think the tox has gone. Over the next few slides, we're going to see pralidoxime's mechanism of action. The figure here represents the active site of acetylcholinesterase, which normally will bind to acetylcholine and then hydrolyze it by breaking its ester bond into a molecule of choline and acetic acid. There are two interesting subsites within the active site. On the left, we see an area with a negative or anionic charge, and this is where the choline part of acetylcholine would normally bind, since it has a positively charged quaternary nitrogen atom in it. On the right side, we see an important serine side chain with a hydroxyl group at the end. And it's a free electron pair on that oxygen that makes the nucleophilic attack to hydrolyze the ester bond in acetylcholine. And it's also the same serine side chain that interacts with and binds to organophosphates. So here comes the organic phosphorus compound working its way to the active site. The serine side chain's hydroxyl group interacts with the insecticide, which becomes covalently bound to the enzyme and inactivates it. Now the patient is given pralidoxime, and the structure and charge of pralidoxime allows it to associate with the anionic site, negatively charged, which attracts the positively charged nitrogen in pralidoxime's aromatic ring. And this brings pralidoxime's terminal hydroxyl group in close association with the phosphorus atom of the organophosphate. This allows one of the free electron pairs on oxygen to make a nucleophilic attack on the phosphorus, creating a new phosphorus-oxygen bond on one side and breaking the phosphorus-oxygen bond on the other side to serine. So now the organophosphate is bound to pralidoxime rather than to the enzyme, and it can diffuse away, regenerating active acetylcholinesterase. Like atropine, pralidoxime also is given by a loading dose followed by a maintenance infusion. The recommended loading dose of pralidoxime is 30 mg per kilogram, up to a maximum of 2 grams, given over 15 to 30 minutes IV. Then you start a maintenance infusion. In adults, this is 8 to 10 milligrams per kilogram per hour, up to a maximum of 650 milligrams per hour, and the maintenance dose in kids is higher on a milligram per kilogram basis. You continue the maintenance infusion until it's no longer needed. And how do you know it's no longer needed? When the patient hasn't needed any more atropine for many hours. But you still monitor the patient for return of any symptoms after you've stopped atropine and pralidoxime. And if symptoms return, it's recommended to treat again for at least 24 hours before any other attempts to wean off the meds. And with that, we've come to the end of this video discussion about atropine and pralidoxime. I'll be seeing you around.